This program is brought to you by Emory University.
Morning, everyone. Welcome to Cardiovascular Grand Rounds. Before we start, I'll give you my final reminder of the year that we're at the end of our kids campaign. We're actually very close to our goal, and that's where we support some children over the holidays. So those of you who have not had a chance to help out and still would like to, another email is going to go out today with a link and stuff. We're supposed to go shopping later this week for the kids, and like I said, we're close to the goal, not quite there. Our usual last minute plea to get us over the top, but the goal is to support about 100 kids this year for the court-appointed special advocate of Fulton County. So appreciate your efforts on that. And then, but do want to welcome you to Cardiovascular Grand Rounds. This morning we have a duo here of Mike McDaniel and Dave Hirsh. From both of them assistant professors at Grady in interventional and EP, and they're going to talk about what has become sort of a new issue again and the correct management. I was just telling Michael before this, I've had 2 or 3 of the primary care folks say, is it time for me to refer these people back to you, because a few years ago you told me just anticoagulate and we'll follow along, and now there's some new data about how to manage cryptogenic stroke. So we'll start off with, I guess Michael's going to start. There we go, Mike.
Well, thanks so much. So we thought we'd title this The Role of the Cardiologist in the Management of Cryptogenic Stroke. And I'm going to start by talking a little bit about PFO closure, and then Dave's going to talk a little bit about extended monitoring for these patients. And I think it's exciting because there is some new data now to discuss, and I think it does bring up some new ideas in this area. So these are our conflicts. I was the site PI for the REDUCE trial, which we'll talk about. Dave's done some consulting for Biotronic. And we thought we'd start with a case example just to kind of talk about, what type of patients we're seeing here. This is a 48-year-old male who had a acute left MCA stroke, underwent percutaneous thrombectomy, and was really left with minimal residual deficits. His past medical history only significant for hypertension. During his stroke workup, he has intracranial carotid and aortic imaging that shows no atherosclerosis. During his hospitalization, he's on telemetry and doesn't have any atrial arrhythmias, and then has a TEE with a bubble study that's significant really only for a PFO with an atrial septal aneurysm and a large shunt. And so, the questions for us as cardiologists is, should this patient receive anticoagulation? Should we think about offering this patient PFO closure? And should this patient have extended ECG monitoring either before or after the closure? And would this be a different recommendation if the patient didn't have a PFO? So we'll try to go through some of those questions as we go through this talk. And we do want to try to leave at least 15 minutes at the end to kind of have a good discussion on the topic. So strokes are very common. We all know this, 800,000 almost in the United States last year. It's the leading cause of disability and one of the leading causes of cardiovascular mortality. And if you look at the causes of stroke, the ischemic etiology is the most common. And then if you look at the different reasons for an ischemic stroke, unfortunately the most common reason is what's termed this cryptogenic stroke. And that's after a workup, you just don't know what caused it. Now the story of PFO and stroke has been evolving, and it started with the link between that there was a higher incidence of PFOs in patients who had had a stroke, in particular those that are younger with cryptogenic etiology, that compared to the normal age-matched population, that if you'd had a stroke, you had about a threefold higher increased incidence of having a PFO compared to the age-matched population. And so this led then to a lot of hypotheses about what is the underlying mechanism. We know that in the normal anatomy of the atrial septum, you have your septum secundum and primum that fuse usually a few weeks after birth. But in about 25% of the population, this fails to fuse, and you have a patent foramen ovale, which allows then for at least a possibility of a small clot to have a paradoxical embolus, like whether the clot originates in the lower extremities or in the pelvic vasculature, coming up then through the IVC and crossing over at just the wrong time. Or there's some thoughts that maybe this tunnel in and of itself leads to stagnation of flow, that it just opens, closes, it allows it to close and the blood becomes stagnant, and a clot may actually form within the tunnel itself. This is hard to prove, but it's at least one of the theories of where these paradoxical emboli could originate. And I think we all know that to diagnose the PFO, it's usually some sort of bubble study, whether it's from a transthoracic or a transesophageal echo. We inject the bubbles, look at it on the right side crossing over, and becomes diagnostic of a PFO. Now, not only has a PFO been associated with a higher incidence in patients with strokes, but the anatomy of the PFO may also make a difference. Now, it's not been consistent finding in a lot of trials, but if you look at a meta-analysis in total, the combination of having a PFO with an atrial septal aneurysm seems to be associated with higher event rates over time than compared to just having a PFO alone. So not only is a PFO more associated with strokes, but then the combination of PFO and an atrial septal aneurysm suggests a higher event rate, which we'll talk a little bit about in some of the trials. It's an interesting association. And then over about a decade to a decade and a half, there were a lot of observational trials, a lot of small trials where people were testing transcatheter closure for PFOs to see, does this reduce the stroke rates? So this is a meta-analysis that really summarizes, I think, probably a decade of observational trials where you can see that in total that those patients who had a PFO and then underwent transcatheter closure had lower recurrent event rates of stroke compared to those patients who then underwent medical therapy. Now, this is observational data. There's a lot of publication bias and also selection bias in these trials. And the other thing about it is medical therapy is quite heterogeneous. It's a heterogeneous population, and it's heterogeneous in terms of the way that they were managed. And part of the reason is that one of the big questions has been out there is, what is really medical therapy or best medical therapy if you've had a cryptogenic stroke? And it's been something that's been evolving and something that we've really not known the answer for. If you look at the guidelines, the neurology community does address this. And so the most updated neurology guidelines suggest that in the absence of another indication for anticoagulation, that clinicians may routinely offer antiplatelet medications instead of anticoagulation to patients with cryptogenic stroke and PFO. And so in both patients with PFO as well as without PFO, if you've had a cryptogenic stroke, antiplatelet therapy, single antiplatelet therapy has really been the mainstay for these patients. Now, this has been controversial, though, because if you look at the data, there's data going in both directions, whether anticoagulation is better or whether antiplatelet therapy is better. This is a meta-analysis, I think, that kind of summarizes a lot of this data, published a few years ago, looking at 12 studies, propensity-matched patients. They've all had PFO and stroke, looking at oral anticoagulation versus antiplatelet therapy. And if you see, you look at it, the data is kind of all over the map, but in total, there is maybe a trend, but it's not statistically significant. So in total, the data suggests that they're pretty equal in terms of recurrent event rates, having antiplatelet therapy or oral anticoagulation, although a trend in the favor towards oral anticoagulation. Now, most of this data is also with Coumadin, and so as we all know, there's a lot of interest in the newer agents, and would this landscape change in the setting of our newer oral anticoagulants? And interestingly, the Navigate trial was actually designed to do that. This was a trial that just recently was stopped, so we don't know a lot about the data, but it was designed to study over 7,000 patients with cryptogenic stroke, and they were randomized to rivaroxaban 15 milligrams or a low-dose aspirin. And just last month, they ended up sending out a press release that they've stopped the trial because the interim analysis showed that Xarelto was no better or no more effective than low-dose aspirin, and it did increase bleeding complications compared to aspirin. So again, I think this is also another trial suggesting that really the standard of care in this area probably will remain aspirin, but it will be certainly interesting to see when this trial is published and presented, what this data looks like, because it has been a controversial area. Now, so that's the observational data. The observational data has shown that there is a lower incidence with PFO closure compared to medical therapy, but then the randomized trials on the topic have been mixed. And so I really wanted to kind of go through all 5 of these trials just briefly so that you can kind of understand why some of the first trials were negative and some of the more recent trials that have published have been suggesting a benefit. So the first trial on the topic was the Closure 1 trial. And it looked at the StarFlex device, which is this double umbrella nitinol framework as a polyester fabric. And this is a device that's no longer available to us. It's been off the market now for several years. And Closure 1 was designed to test PFO closure with the StarFlex device, randomized 1-to-1, just over 900 patients, and it was tested against best medical therapy. As in many of these trials, the best medical therapy has not been known, so it was a combination of either antiplatelet therapy or oral anticoagulation. And when they presented the results, they found that PFO closure with the StarFlex device did not have any benefit. When they looked at the composite of recurrent TIA and stroke, there was no benefit with closure. And if you looked at just stroke alone, again, no benefit to PFO closure with the StarFlex device compared to medical therapy. And so there was a lot of questions that this trial brought up. You know, why were the results of Closure 1 negative? The observational trials had looked so promising, yet the Closure 1 results were pretty solid negative. And so there were, you know, some things about the study that could explain these results. First, all the trials have had an entry bias in that some of the patients are higher risk patients are closed outside the study. But there was also problems with just the design of the trial. 28% of the patients in this trial had a clinical TIA as their entry criteria, but did not have any imaging confirmation of a stroke. And I think that some of the more recent trials have learned from that and have excluded TIA and really made it an imaging confirmed stroke in subsequent trials for patients undergoing PFO closure. They also had no exclusion for lacunar strokes, and pathophysiologically it doesn't make sense that PFO closure would help with lacunar strokes. It really is really after the embolic etiology, and so these lacunar strokes would probably not have any benefit with closure. And then most importantly, though, about 50% of the endpoints in the device arm seem to be a problem with the device. And we know that the StarFlex has its problems. So this is a large meta-analysis looking at the StarFlex device compared to the Amplatzer and the Helix device from Gore, which will show some data in a minute. And the bottom line is when they looked at it, there was much higher rates of thrombus formation actually on the device compared to the other two, as well as much higher rates of atrial arrhythmias. So it may be that the device was causing just as many problems as it was trying to solve from PFO closure, and so that a lot of this could be a design flaw within the StarFlex device. So that then led to subsequent studies looking at different devices, and probably the most studied now is the Amplatzer PFO occluder. This is similar to the Amplatzer ASD devices. It's a self-expanding nitinol wire mesh. It comes in multiple sizes, usually a 25 millimeters, the most common size used. It's recapturable, it's repositionable. I think many people are familiar with how the technique is done, but just for those who may not have seen it, you come up through the IVC to the right atrium, you cross over the PFO with a wire, you bring up your delivery sheath, you then deploy the left atrial disc, pull the left atrial disc back against the atrial septum, then deploying the right atrial disc, leaving it with a kind of pancaked in the middle here, and then you unscrew the delivery sheath. So the Amplatzer device has been studied in now several trials. The first of which was the PC trial, and this was published several years ago in New England Journal. And it was a smaller study. It was 414 patients, and it was randomization of closure versus medical therapy. And again, this was another negative trial for PFO closure. When you looked at closure, the recurrent event rates were lower numerically than with medical therapy alone. However, this difference did not reach statistical significance. And also, when you look at the absolute benefit, it's about a 2% difference here. And so your number needed to treat, even if it were statistically significant, was pretty clinically insignificant with a high number needed to treat. So this was another negative study about PFO closure. But if you go back through and say, well, what was different about this trial as opposed to the next three that we're going to show, is one was that the anatomy of the PFOs were a little bit, quote unquote, lower risk. They had less atrial septal aneurysms in this trial than we will show in some of the other data. And when you look at large shunts, there was a smaller number of large shunts. The other way of saying it's a lot more small shunts in this group. The other thing about it, in the PC trial, about 30% of the patients were on oral anticoagulation, which it's interesting, but does dilute the impact of PFO closure compared to medical therapy. And so some of the other studies more recently published have really tried to go head-to-head against antiplatelet therapy, which is considered the true standard of care today for this group. So in the same New England Journal, another trial was published several years ago. This was the RESPECT trial. And we're going to talk about this in a little bit more detail because they've just published the extended results. So this was the larger of the two trials. It was almost 1,000 patients. They were randomized 1-to-1 to device closure. Again, this was with the Amplatzer device compared to medical therapy. And if you look at the breakdown of medical therapy, again, it was a hodgepodge of medical therapy, most of it antiplatelet therapy, but about a quarter of the population was on oral anticoagulation with warfarin in this study. A couple things about this population, and I just want to highlight these as you see when Dave talks a little bit about loop recorders and some of the extended monitoring, is this is a low-risk group. This is a young population. The exclusion criteria was age 60, and this is going to be an exclusion for all three of the trials that I want to go through here. Young population, averages in their mid-40s, with really no comorbidities. They're excluding vascular disease, excluding heart failure, and then really you're left with very little in the way of cardiovascular risk factors. A little bit of hypertension that's controlled, but otherwise a low-risk population. This would be a low CHADS-VASc type population. The other thing about the RESPECT trial, in comparison to the PC trial, which we just showed, is that the anatomy of the PFO was a little bit higher risk. So, I'm going to go back. Sorry about that. So if you look at it, about half the trial had grade 3 shunts. And now we may need to start thinking about grading our PFOs as we think about doing our echoes and how we discuss these. But whether in this trial it was at least 20 bubbles was what was considered a severe shunt with either at rest or post-Valsalva. You can see that this has been graded a little bit differently, but above 20 bubbles, a large shunt, a lot of bubbles coming across quickly. So not just those trickle of 1 to 2 little bubbles where you're really squinting to see if there's a PFO or not. I mean, these are obvious PFOs. The other thing about it is over a third of the population had atrial septal aneurysms in this study. So again, when this was published several years ago in New England Journal, it was a third negative trial that was published, and really another negative for the PFO closure idea. But what you saw was that there was less recurrent events in the closure group compared to medical therapy. But it was a negative trial because in the intention to treat cohort, this was not statistically significant. There was not the p-value did not reach statistical significance. But it was known in this original publication that in this closure group, that 3 of the 9 events that occurred in the device group occurred before they had gotten their PFO closed. So their events occurred while they before they'd had the closure of the device. So they went then back and did an as-treated analysis in the original publication, and showed that when you looked at actually how patients were treated, whether they got their device, whether the PFO closed versus were on medical therapy at the time, that device closure did reduce recurrent event rates and recurrent stroke. Now the relative benefit is actually quite striking, about a 73% relative risk reduction. But when you look at the absolute reductions, they are on the more modest size, because both patients that are getting closed as well as those that are getting medical therapy largely are doing well. And that's one of the dilemmas in this whole group. But this was a significant reduction. But because it was not in the intention to treat, it was considered a negative trial. So I think where this story has now come is now that there have been 3 new publications that were just recently published in the New England Journal that have re-looked at some of this data. One of it was a relook at RESPECT, and then there's 2 new trials that I'm going to show you. So they then followed this RESPECT group out to an average of about 6 years. And once they followed up with extended follow-up, it was shown that the PFO closure group reduced the rates of recurrent events compared to medical therapy. Now, the absolute benefits were still somewhat modest, with a number needed to treat of about 42 to prevent a stroke at 6 years follow-up. Now I want to just highlight what that number needed to treat means, because I want to show you a couple other slides here. And so one of the things that you can consider, I think, is another thing that we do to try to reduce strokes is carotid revascularization in the asymptomatic population. So if you listen to a neck, heard a bruit, got an ultrasound, saw severe stenosis, got a CTA, confirmed a stenosis, and then sent the patient either for carotid stent or carotid endarterectomy, you would be doing that to try to reduce the event rates of stroke about 1% per year, or at 5 years, about a 5% absolute reduction. So carotid stenting and carotid endarterectomy, you have to do 20 procedures to reduce 1 event rate at 5 years. So if you look at PFO closure, it's not in that realm, at least in the RESPECT data. But what's interesting then, if you start to go then look at some of the subgroups in RESPECT, if you look at shunt size, if you had a large shunt, your absolute reduction was much greater. Your number needed to treat of about 20, so in that similar range. Whereas if you didn't have a big shunt, there was no benefit. Again, if you had an atrial septal aneurysm present, your number needed to treat of about 17, if you didn't have it, there was no benefit. And interestingly, when you looked at those that were randomized against antiplatelet therapy, really the standard of care, again, a benefit to PFO closure, number needed to treat about 27, whereas if you were on anticoagulation, no benefit. The other thing about the RESPECT trials, if you looked at these serious adverse events, is that the event rates were low. In this group, they did not see a higher incidence of atrial fibrillation, but I'm going to point out in the next 2 trials that was not the case of the other 2 trials. But in total, a pretty low adverse event rates. You see that most of these things occur very rarely with PFO closure. So in the same New England Journal that the extended RESPECT trial, 2 other trials were published. Now the closed trial was one of those other 2 trials. Again, it was a pretty good sized trial, 663 patients. The age cutoff was 60, so you're going to see that that's really the ceiling on PFO closure is age 60, at least in the trials, in the randomized trials. They had cryptogenic stroke, which is again confirmed by a neurologist, and a true stroke, not a TIA, but a true stroke. And they tried to enrich their population and actually looked for an anatomically higher risk. They either had to have an atrial septal aneurysm or a large shunt, which they defined as 30 bubbles crossing and 3 cardiac cycles. Again, just like RESPECT, this is a young population, average age in the 40s, without much in the way of risk factors. So these are not patients that have vascular disease, heart failure, hypercoagulable states, or other needs for anticoagulation. These are low-risk patients that really have no other medical problems other than a stroke and a PFO. So when you look at the closed trial, and you look at their follow-up out to about 5 years, there was about a 5% absolute risk reduction in recurrent stroke compared to medical therapy. So this number here, about a number, 5% absolute risk reduction, or a number needed to treat of about 20, so 20 closures to prevent 1 recurrent stroke rate. Again, in line kind of with what we do with with carotid revascularization in the asymptomatic population. And again, this data is similar to what you see with the RESPECT trial if you look at those subgroups that were similar with aneurysms, large shunts on antiplatelet therapy. And now in the closed trial, they did find that there was a higher incidence of atrial fibrillation. And I think that this is a true finding. When you put a device in, it probably does irritate transiently the atrial septum. It shouldn't surprise us. And so what you do find is that there is transient atrial fibrillation that's higher. In this population, most of the patients were placed on oral. Of the 11 patients that this occurred, 10 got anticoagulation. Transiently, the AFib then went away, and they stopped their anticoagulation. And there was no events in that group. So the third trial is the REDUCE trial, and then I want to go through this and then turn it over to Dave to talk about loop recorders in this population. This was looking at the Gore septal occluder, and we were at Emory. We were one of the sites, also St. Joe's. With Spencer Polymer was one of the site PIs at St. Joe's. So two of our sites included patients in this trial. So the Gore device is a little bit different than the Amplatzer in that it's a PTFE occlusion membrane with a nitinol frame. It's much more compliant and flexible than the Amplatzer device. Now, the REDUCE trial, I thought it was a pretty nice design. Again, a pretty good size, 664 patients. They use that 60 age cutoff. So all three of these trials, again, 60 age cutoff, cryptogenic stroke, confirmed by a neurologist, seen on an MRI, consistent with an embolic etiology, not lacunar. Randomized to PFO closure versus antiplatelet therapy. And this was this whole trial was against the standard of care of antiplatelet therapy. They had really no anticoagulation in this group, and I think this really represents a true trial of what contemporary practice is. Again, just as we showed earlier, this is a young population that doesn't have in the way much of comorbidities. If you're finding heart failure, if you're finding a lot of vascular disease, if you're finding other hypercoagulable states or other things, this isn't the group for PFO closure. In this population, there was a larger number of large shunts, and about 20% had atrial septal aneurysms. When you looked at the event rates, this study was up to 3 years. Again, compared to medical therapy, which was just antiplatelet therapy, PFO closure had about a 4% absolute risk reduction in recurrent stroke compared to medical therapy. So again, a number needed to treat at about 3 years, of 25. Now they had two primary endpoints. One was the clinical stroke, but they also, everybody came back for an MRI, and they re-looked and said, did we see any new brain lesions on the MRI? And there was a significant reductions in new infarcts on an MRI compared to the antiplatelet group. So that the absolute risk reduction, a little bit over 5%, number needed to treat of about 18. So if you take RESPECT, CLOSE, and REDUCE in total, you're seeing that between 3 and 6 years, that you can get about a 4 to 5% absolute reduction in stroke, which translates into a number needed to treat of about 20, I think, to prevent a stroke. So all three of them pretty consistent. Now, what was interesting in the REDUCE trial, unlike the other trials, is they didn't show a major difference in terms of the size of the shunt. So it does bring up, is it just the large shunts? We need to look in this more, but at least it's one, it's still a question out there, I would say. Now, what we did see again in the REDUCE trial was higher atrial fibrillation compared to medical therapy. So the devices are irritating the atrium transiently. Most of this occurred right after the procedure, within the first month or two, and most of it resolved very soon afterwards. So it seems to be a transient phenomenon, but it's something that we need to continue to look at, and how this relates to the benefits of PFO closure still remains to be seen. So what do the guidelines say? Well, this is, I think, where it's interesting is that, we now have 3 trials. Now, these trials came out before the guidelines were released, but the guidelines are somewhat at odds with where the data is. Currently, the recommendation for PFO closure is a class 3, and it says the clinician should not routinely offer this to our patients with a cryptogenic stroke outside of a research setting. Now, what's interesting is I think some of the politics involved in this is that my understanding is that the guidelines knew that some of this data was coming out, but they chose to release this ahead of some of the data, which really kind of just shows that there are some, at least academic politics also going on here in these guidelines. So we have to think about that. So it'll be interesting to see what the new guidelines say. So I think I want to turn this over to Dave now, but my conclusions, at least for the PFO closure, and then maybe we can wrap it up at the end about how to handle these patients from a monitoring standpoint, is that I do think PFO closure should be considered in some of our patients. Not all of our patients, but some of our patients. And I think it really has to be a true cryptogenic population. We really need to be partnering with our neurologist and find out that these are cardioembolic etiology, no vascular disease, not a lot of risk factors, no hypercoagulable states. It should be our young patients. The exclusion criteria for these trials used age cutoff as 60. And maybe we just need to start off by focusing on those with the larger shunts. Whether we define it as 20 or 30 bubbles or just an eyeball estimation of a lot of bubbles crossing over or having an atrial septal aneurysm. But maybe those little twinges of little puffs or two, maybe that's not really the population that we need to be targeting. And again, these are patients that are going to be on antiplatelet therapy. If you're going to be putting somebody on anticoagulation for whatever reason, it may not be that a benefit to close the PFO. So with that, I'm going to turn it over to Dave to talk about searching for atrial fibrillation in this population, because this does relate.
Good morning again. Dave Hirsh. I'm over here every once in a while. I've been an electrophysiologist over at Grady for a few years now, but I don't get a chance to see everyone here. So in case you didn't see me, this is who I am. I get referred an awful lot of patients for cryptogenic stroke at Grady because of the stroke center. They range in age from elderly to extremely young. They have real strokes, thrombotic material removed from their vasculature, and what to do for them is a challenge, both when they have a PFO and when they don't. I'm usually referred to look for occult atrial fibrillation, which is what I'm going to talk about. Everyone in this room knows that AF is frequently asymptomatic and can be sporadic. The risk of embolism is increased maybe 5 times, something like that, obviously stratified by what your other risk factors for stroke are, diabetes, hypertension, etc. And occult AF is maybe an etiology of CVA. Now, interestingly, the precise amount of AF that you need to elevate your stroke risk is somewhat unknown and may vary. I'll show you some data that suggests it may vary based on your CHA2DS2-VASc score. And the direct causal relationship between AF and CVA may be somewhat unclear. I had a slide in here showing like TE and a thrombus and an EKG of AFib, like something you might see in medical school, something other departments we might show them. But that kind of one-to-one correlation may not exactly be the way it works in all patients all times. AF may be the worst risk factor one could have for a stroke, or something about being an AF may trigger some other stroke mechanism in patients. But it lends credence to the idea that occult AF may be associated with stroke and may be a treatable risk factor that you can reduce for recurrent stroke. The largest data set that links occult atrial fibrillation or subclinical atrial fibrillation with ischemic events and embolic events comes from the ASSERT trial. The ASSERT trial is a complicated trial. It was essentially a monitoring trial of about 2,500 patients with hypertension and no prior history of AF who got pacemakers and ICDs recently implanted, and they were monitored for 3 months. The trial also had another arm looking at a pacing strategy to try to reduce atrial fibrillation. So they tried to kill 2 birds with 1 stone in this trial. They considered anyone to have an atrial arrhythmia who had an atrial rate of greater than 190 beats a minute. They used a 6-minute cutoff, and they followed the patients out to 2.5 years, although after the 3-month initial visit, they only saw them about once every 6 months. By 3 months, 10% of the patients had a subclinical atrial arrhythmia. I think if you're in a device clinic, you see this just routinely. I mean, I see this in my device clinic, which we run every day. Every single day, people coming in with subclinical atrial arrhythmias. And subclinical atrial fibrillation was diagnosed in 51% of the patients who had a CVA or an embolic event. And atrial arrhythmias entirely were associated with AF and with embolism. And that speaks to how we may treat some patients that we see what we think is PAT or something on their ICD or pacemaker. Should we anticoagulate those patients? Should we wait for them to have AF? That becomes a difficult question, and on a personal level, I stratify that by the other risks of the patient. If they have a lot of other CHA2DS2-VASc score, if their EF is abnormal, I might favor anticoagulation. If they've had a prior ablation, et cetera. If they're young with no other risk factors, maybe I'll watch them. Interestingly, you may come across in the literature this idea of the lack of a temporal relationship or consensus on a temporal relationship between atrial fibrillation and CVA, and that's primarily from this retrospective review of the patients who had an event in the CERT trial. What was known is that subclinical AF was detected 30 days prior to a stroke in only 4 patients who had a CVA, which is exceptionally small. AF was associated with the events, but without a temporal relationship, even though that subclinical AF increased the embolic risk by 2.5 times. This is a small data set. It's out there, it's confusing. I don't know what it means. They didn't necessarily tell you what kind of strokes the patients have. I'm not sure about the relevance of this particular trial, but it's out there. You'll find it on UpToDate. You'll find it in discussions of this topic. But I think that this is a better data set, which is a little bit published a little bit afterwards, which is almost 10,000 patients followed over 10 years at the VA. They were all on remote monitoring. They all had, I believe they all had Medtronic devices where they could monitor for atrial arrhythmias, and they did it remotely. And they had 187, so almost 3 times as many CVAs. And they compared the AF burden for 30 days prior to the event to 90 to 121 days prior. And what they found, and an AF burden for them was a minimum cutoff of 5.5 hours of AF. But found that the odds ratio for a stroke, a CVA, was highest in the 5 days after an AF event and decreased after that. And that to me makes a lot more sense. And it just sort of dropped off. I mean, it makes perfect sense, actually. If you saw someone who had transient AF after some gallbladder surgery, and then you're out 5 years and they've never had an AF event, you would expect their rate of that event to drop to almost what its baseline rate was. And that's exactly what they found. This, to me, suggests that there's a strong relationship between the presence of AF acutely and the presence of a stroke. Now, what that relationship is, I don't know if it's a thrombus in their appendage or something else, but it lends credence to the more classical ideas about AF and stroke. In terms of the duration of AF that one would need to have a stroke, and this comes up frequently, no one has the answer to this. Trials use all sorts of different cutoffs. This is the nicest trial that you will find because it divides the patients both by their burden of AF and by their risk, their CHA2DS2-VASc risk. It was a retrospective analysis of 568 patients with a pacemaker and a history of symptomatic AF with continuous monitoring for a year. And what you find is that the event rate is 0.8% if you are AF-free, which was less than 5 minutes, with a CHA2DS2 score of less than 2, less than or equal to 2. If you had 5 minutes of AF with a CHA2DS2 score of less than 1, or if you had 24 hours of AF and your CHA2DS2 score was 0. That makes sense. That's consistent with how we would think about AF. Everyone here knows about the monitoring strategies that we have for AF. They're the same as for other dysrhythmias. There's continuous ambulatory EKG monitoring, which is all EKG data for 24 to 48 hours. With a patient-activated event monitor, that could be something like a Holter monitor or a Zio patch that you see now. There's event loop monitoring, which is I'm not sure how applicable that term specifically is now because we have MCOT available as well, which is where the data is continuously transmitted to a central server technician and you get real-time feedback on your patient's arrhythmia and arrhythmia burden. And then there are implantable loop recorders. This is what you might see. I show at the bottom, this thing, if anyone's seen, there's a commercial on it on TV for this now, this a life event or life core or something they call it. I can't remember the exact name. I've had a couple patients come into the office with it. Essentially, it's a patient-initiated event monitor that attaches to your iPhone where you touch it, it uses your fingers as a lead 1 electrode, and it gives you a recording of that event at the time. The only issues I've seen with this fidelity, the patients love it. It's very empowering. This is the Zio patch. If you haven't seen it, it has a clicker here for patients to trigger a monitor. And an MCOT and a Holter basically look the same as an external monitor. These are implantable loop recorders. I'm sure by now most people have seen these. They've been out for a couple years. This is the first generation, a little bit large, needed more of a surgical technique to put it in. They could flip if you didn't put them deep enough or sew them down. This is the Medtronic loop recorder. This is the only one I've ever used. There is a Biotronic loop recorder. It's really large. It has an antenna on it. I've never used it. I'm not sure it's on contract at Grady. The only person I can imagine using it is someone who's got a lot of tissue, maybe large breast, because the sensing on this can be a little bit off if there's tissue moving away from the chest wall, but I've never used it. This is how we implant this device. It's a little nick in the skin. It's injected underneath the subcutaneous tissue. I tell the patients it's like an earring, or it's better than dental work. I'm happy to give them a little sedation, makes them comfortable. I know some places just use local. We've used just local on plenty of patients. They go home with a transmitter. It uploads data to a central server. It gets pushed to us every 24 hours. If the patient goes somewhere else, which is an issue for us because patients have strokes, they come to Grady and then they go back wherever they came from. They can re-register, and the data will no longer get pushed to you. It gets pushed to your colleagues in Athens or Augusta or wherever the patient's being followed. They work remarkably well. The sensing is pretty good. It has its own algorithm to detect AFib. That has its own pitfalls with frequent PACs and frequent PVCs, which can be a little bit challenging to figure out the arrhythmia. But all in all, it's a remarkable device. It lasts 3 years, and it's an excellent adjunct to try to figure out what's going on with your patient. This is just a table kind of illustrating the pluses and minuses of the various monitoring techniques. And as you can imagine, if techniques that are of shorter duration have a lower yield, and those that are on your skin surface as opposed to in your sub-Q, the patient has to be a bit more of a participant with. So the yield's going to be highest with your subcutaneous implantable loop recorders. Whether that is appropriate for everyone at all stages, I'll talk a little bit about at the end. But I think they're pretty useful for most of our patients with cryptogenic stroke. There's 2 large trials looking at long-term monitoring for patients with cryptogenic stroke. The first trial was the Embrace trial. It assessed a 30-day automatic event recorder. There's a event recorder. I've not used it here. The trial was done primarily in England, and it seemed to have some kind of proprietary software to have an automatic detection for atrial fibrillation. So patients were 55 years or older. They had a cryptogenic stroke or TIA within 6 months. They had no prior AF. They had had at least one prior 24-hour monitor. They had a TTE and a TEE, which in the appendix they will tell you was left to discretion to determine whether there was any cause of stroke based on the results of those tests, and they were excluded if they had a likely diagnosis, like they had obvious carotid stenosis or big plaque waving in the wind somewhere. And the patients were randomized to a 30-day automatic event recorder or an additional 24-hour monitor. The most important thing about this trial is that the patients were much older. They were on average 73 years old, plus or minus about 8 years. And they had a lot of diabetes. It was about 20% diabetics in both patient groups. And I point that out because the yield of this intervention was extremely high. So these patients were within 6 months of their cryptogenic stroke, and the AF detection rate, with just a 30-day monitor, was 16%. That's extremely high. Compared to other data in the literature. And I think that is largely related to the age and risk factors that the patients brought to bear in this trial. And I think that's a general consensus in the literature as well. There are quite a few small and moderate-sized registries of implantable loop recorders for long-term monitoring for patients with cryptogenic stroke, although the best trial performed was something called the Crystal AF trial. The rest are small kind of case series and retrospective reviews. The Crystal AF study was meant to assess the benefit of an implanted loop recorder. They used the Medtronic implanted loop recorder versus standard of care, which is basically whatever the doctors wanted to do. for the AF detection for cryptogenic stroke. The patients were 40 years or older in this trial. They all had a cryptogenic stroke. They all had EKG, at least one Holter monitor, a TEE. They had a CT MRI of the head and neck, and they all had hypercoagulable screening if they were less than 55 years old. That comes up when, and the fellows at Grady know that I typically require that younger patients have a hypercoagulable workup before I'm willing to implant a loop recorder. My personal bent is that I kind of stratify that based on their CHA2DS2-VASc score. I think if you're 50 years old and you have hypertension and diabetes and an EF of 45%, you're probably more likely to have AFib than a hypercoagulable state. But if you're 25 years old, patient group I'll talk about at the end, and have no risk factors, well, I'm not sure you're likely to have AFib. I'm not sure what's wrong with you. So I usually leave that hypercoagulability workup to the discretion of the neurologist and the hematologist, and they can decide what's appropriate in that patient, kind of stay in my lane. The Crystal AF study enrolled patients in their 60s, which is, it's a lot younger. I mean, it's almost 15 years younger on average, these patients. And you can see the CHA2DS2-VASc score of the patients, assuming that if you had a stroke, you were CHA2DS2-VASc 2. You have about 60% of the patients are CHA2DS2-VASc 3 and 4. So this is a really interesting subset of patients, kind of middle-aged patients with reasonable CHA2DS2-VASc risk score. And it begins to show you how long you might have to monitor someone to find atrial fibrillation. Again, it's not a trial of a therapeutic trial. It's a trial of how often you find AF in these patients who had had a stroke. I mean, that's a philosophical question, but it's a scientific question as well, and it's important. By 6 months, they found about 8% of the patients who had had a loop recorder were found to have atrial fibrillation versus about a 1.5% in the control group. This was extended out to 12 months, and the difference began to increase. And 81% of the patients were followed out to 36 months, at which point the detection rate was 30% versus 3%. Now, I don't have all the patients that I've implanted loop recorders in at Grady yet in a registry. As a result of doing this over the last few months, I'd like to create a registry, particularly with our younger patients. But I will tell you anecdotally, in these types of patients, this is about what I see. And I think because we have a strong selection bias for very severe types of strokes at Grady, like the real deal, the embolus that they see on angiography, et cetera. What you see is that if you're older, it seems like your AF detection rate's a little higher, and it seems like there's a trend. As your CHA2DS2-VASc score goes up, your detection rate goes up. That all makes sense to me. In fact, it raises the question, if screening was easy enough and cheap enough and low enough morbidity, should we screen other people who've never even had a stroke for the presence of atrial fibrillation? That is something that seems like it's coming in the patient-driven self-monitoring era. I don't know the answer to that. The number needed to treat is probably high, but I could see it happening one day. There are a number of predictors which are in no way remarkable to find AF after cryptogenic stroke. Older age, any prior chronic appearing stroke on imaging, obviously excluding lacunars, left atrial enlargement or LV dysfunction, and frequency of PACs on EKG or telemetry. In fact, Alan had referred a patient to me. I did an A-flutter ablation on the patient like 3 years prior for tachycardia-induced cardiomyopathy, and I could see he had a lot of ectopy on his monitor, and Alan wanted me to put a loop in him, and he was hypertensive, and I said, he'll have AFib for sure. The guy had AFib within like 48 hours. It was just randomly never picked up on monitoring. So the usual things that we think are associated with AF. So this is my teaching point, as it were, or what I lean on when I make these decisions. I don't think it's groundbreaking. The likelihood of finding AF after cryptogenic stroke is proportional to the pretest probability of AF and the duration of monitoring. Seems to help. Now, as a result of these trials, the guidelines have changed. They haven't, or some guidelines have begun to evolve, should I say. They haven't suggested that we implant loop recorders in patients who have cryptogenic strokes across the board, but they suggest that you consider it and additionally consider some type of long-term event monitor. So here would be my summary for long-term monitoring after cryptogenic strokes, that loop recorders detect low-burden asymptomatic AF. They may be an effective tool for prevention of recurrent stroke in patients less than 75 years old. Patients greater than 75 years old may be suitable for an event recorder prior to a loop recorder. And data for long-term monitoring is not available in a younger cryptogenic stroke population. It's still a confusing population. And Mike and I talked about this a lot when we were playing guidelines authors in our offices right next to each other at Grady. And we would talk about who needs a loop recorder and who needs a PFO closure and what do you think about this. So we collectively kind of put this algorithm together on the data as we conceive of it. And Mike spoke to you about his end about all the patients being less than 60 in the PFO closure trials. On my end, the patients, I think, that are greater than 60 should get a loop recorder. Whether they should, if you're greater than 75, you should get an event recorder first from an economic perspective, just because the yield seems to be so high. I'm not sure. It seems reasonable. I will say if you are younger, like this, greater than 40, less than 40, and have a stroke, I'm not sure what to do if you have no risk factors for AF. I'm not sure if a loop recorder will help you or not. I put them in because the neurologist asked me to. And it's a devastating event, especially for these younger people. And I see the morbidity as being extremely low. I have yet to see an extremely young patient have AF. I'm sure there's one out there. There's one out there with some channelopathy, which we haven't identified yet. But I think the yield is probably very, very low. And I don't have the answer to that. Mike and I talked about putting a registry together of those extremely young patients. There isn't one in the literature. There isn't a registry of even 50 patients who are 40 years or younger with cryptogenic strokes. So hopefully we'll be able to do that and publish it. Thanks.
All right, so lots of controversial things to discuss. We'll open up for questions. I'll start with one. And Mike, it's one we sort of talked about at the beginning. And so what about the patient who you haven't closed a PFO, had their event 10 years ago? That's going to be sort of a bit of a dilemma, because have they passed the test of time and that they've not had a recurrent event, or are they just simmering along waiting to have an event? And I think you're going to get a lot of those questions probably from people that are being followed.
Yeah, that's a great question, and for which there really is no answer. I think we'll just have to individualize that. I mean, the pathophysiology is there, so it hasn't changed. Whether the test of time means that this person is not going to have the recurrence, we just don't know. But I would say that if I was going to talk to somebody who'd had the event 5 years ago, 10 years ago, I would look at the anatomy of it. Is there an atrial septal aneurysm? How big is the shunt? What are their other risk factors? And how young are they? The younger you are, the less risk factors that there are to explain the stroke, and that the anatomy of the PFO is more, higher risk. The more I would, consider that. But I think you have to individualize it and, talk to the patients about this, because there's no right answer.
Questions?
First, several things to remember. One, PFOs can change over time, that they're not necessarily the same. That is, some of them will close, some of them will get larger. I think my own thing of looking at this, the thing I'm most troubled by is the idea of using an antiplatelet agent rather than anticoagulation. Because what you're doing is you're talking about the problem of the thrombus is coming from atrial fib. You're looking for atrial fib, looking for atrial fib. And our tender thing to treat atrial fib is with Coumadin, an anticoagulant. And so I think in my mind, that was the only way I differ with what was outlined, is that I would say that if I decided to need to treat it, I'd put them on an anticoagulant, not an antiplatelet drug.
I mean, it's a great point, and if you look at the data out there, there was no benefit to PFO closure in those that got randomized against anticoagulation. With that said, it'll be interesting to see what the Navigate trial shows. But I thought intuitively it made a lot of sense to take the cryptogenic population, throw them on a NOAC once a day, don't have to monitor them. It's effective. It's a great, has less bleeding, etc. And at least that strategy is not panning out in a population.
You have some differences, though. If you look at all the meta-analysis, there's, in one slide you showed there, showed some differences.
I mean, I agree, and I think it'll be fun to look at that trial and see maybe there's some subgroups in there. Maybe the PFO, group will be different, but it's a controversial topic of what the best medical therapy is. Angel asked a question too and said, are we sure that the AFib is transient in the PFO population? Because those two trials did show an increase, and the answer is we don't. They didn't have a loop in, and we've talked about, should we be putting loops in some of these patients who have had a PFO, that have higher risk? Should you be monitoring for the occult AFib in that population? There's no data out there on that, and we don't know in that population, were they having more AFib than they had. All you can say is that it was clinically brought up, and they didn't have any more of the clinical AFib. So it seems like it was transient in both of the trials, but we don't know.
I think Mike and I were talking about that a couple weeks ago, and it seemed like they didn't have any more AFib in those trials, and they weren't treated after that. But I kind of raised the question with him: was the PFO closure an AFib diagnostic technique? That we put a lot of catheters in left atriums and do a lot of transeptals, and we don't see a lot of AF. That being said, we're not smashing something and closing the atrial septum and causing a lot of edema, etc. But it's it's not a common thing to put a catheter across an otherwise normal patient and just get AF all of a sudden. So I don't know if you're selecting for higher risk patients, but they didn't seem to have it afterwards, and they weren't treated afterwards.
So that was a fantastic duo. I learned a lot, and it was really a great format for education. So I guess a question for David. I think if I take away from your nice review is that the clinical predictors of stroke or AFib are pretty strong. And so when you put in your loop recorders, you pick up almost 30% of these patients having AFib, but you could have pretty much predicted a lot of that based on the clinical parameters, or Chad's VAS score and other things. So how do you view the monitoring of AFib to alter your management? Because you have an older patient with high risk of stroke, wouldn't you put those on anticoagulation to begin with, or can you make a case for putting in a loop recorder that would change management?
Well, I mean, that's a good question. It's addressed in the Crystal AF trial specifically, essentially. It's not a therapeutic strategy trial. I'll tell you that the therapies were changed in the patient in whom AF was detected, and the subsequent event rates for stroke were dropped as a result of detecting AF, presumably, and treating them with anticoagulation. The notion of treating them with anticoagulation based on their Chad's VAS score prior to the identification of AF is a reasonable third arm for a strategy. If you take patients who you're going to say, we're going to monitor this group and only treat if we find AF, we're going to do standard of care in this group, and we're going to just treat based on a high Chad's VAS and age, or some combination of risks in that group. That's not currently the standard of care. You only detect 30% by 3 years. So if you're monitoring 24 hours a day, 7 days a week, that means you're not missing it. It's not as though you're putting Holters on and missing it in the interim. So that's a lot of patients who are going to get treated who didn't have AF. Now, I don't know how that would work out. I don't know. I suspect the number need to treat would be lower than the number needed to harm. I think you'd harm more patients than you help, but I don't know.
My thought is that Navigate trials probably had some of those patients in it. And, at least as a trial as a whole, did not find that just putting them on rivaroxaban, reduce that event rate. We'll have to see, though. That's, this, I'm making a lot of guesses based on a trial that stopped and not published yet, but, so we probably just need to wait.
I'll tell you the patients that I do see that in, that I get referred, are especially Grady, and this causes some confusion, is the patients with reduced ejection fraction. My clinical practice has been I've been referred a number of those patients before they have a ICD, so they can't be monitored, obviously. And maybe before I would consider putting an ICD in based on what medical treatment they've had, or we see transient reductions in LVEF after stroke, et cetera. But my practice has been, if your ejection fraction is reduced, then the lower it's reduced, the stronger, is my opinion, is to treat them empirically with anticoagulation and not to put in a loop recorder. It's a similar type of.
So this was a secondary prevention type talk, right? So patients had previous events, but when we look at echo reports, we see atrial septal aneurysm. The patient freaks out. They got an aneurysm in their body. They're going to die over the weekend. There's variability in how people read atrial septal aneurysms. But my assumption would be that for patients who just have an atrial septal aneurysm and a small PFO, there's really no data on what to do. That's one question. And then the other related to atrial fibrillation, we have a lot of patients who have atrial leads in their heart that are undergoing continuous monitoring with dual chamber defibrillators and that type of thing. And yet I see very little standardization on what the length of atrial fib detection would be on a device that will alert you from home. So one question is, why has there not been more work around that? There's certainly a lot of work on trying to determine who should get an implantable loop recorder, but what is the standard for somebody with an atrial lead as to when you would want to know that they have atrial fibrillation?
I mean, so how much AFib would you want to know that they have before you?
Yeah, I see patients who come in and get their device checked, and the tech will say, oh, well, they had atrial fib that lasted 12 hours 3 weeks ago, and it's like, well, when do I really want to know when they had 5 hours worth? What is this, when people leave the EP lab and go home, what should that parameter be set at, and should it be based on their CHADS VAS score?
That's an excellent question. I mean, there's no standard. There's no standard that I'm aware of where people are practicing the same. I don't know the answer to that question. I would think that the higher your CHADS VAS score is, the lower that number would be that you would tolerate for atrial arrhythmia and atrial fibrillation. But I'm not aware of a standardization across electrophysiology laboratories and physicians where they'll say, I want to be triggered if the person has 5 minutes of atrial fibrillation. And it's probably a failing of the home monitoring and the number of patients we have. And there just is no answer to that. I mean, it's an excellent question. It's frightening when you see them sometimes in patient. You're like, wow, in clinic rather. They come in with heart failure and they've had AFib and haven't been noticed. There are some issues, obviously, with home monitoring, that it's not available for everyone. At Grady, we deal with landline versus cell phone, et cetera, some of those issues. But assuming someone has access to that, I mean, it's a good question. I don't have an answer.
And just
Did we have one more quick one back there?
I was just going to comment on I agree with you about the PFO. If you've never had a cryptogenic stroke, that there's so many people out there with a PFO and atrial septal aneurysm that probably no therapy until you've had an event. There's no data on that, but
You have to get to a microphone. Okay.
Just don't use the word aneurysm.
So sometimes in Grady, if somebody comes in with cryptogenic stroke in Grady, prior to getting a loop recorder, sometimes they ask for a TEE to look at the clots in the left atrial appendage. Is there any data supporting that, and what's the pickup rate on that in terms of finding it and treating it?
That's a controversial topic. As whether there's consensus on whether one ought to do that. We do it at Grady because that was part of the enrollment criteria for Crystal AF. The devices are expensive, and my clinical decision was to follow the enrollment criteria of the trial, which established the efficacy of this monitoring device, and not to re-adjudicate whether TEEs were vital in all those patients. I think that in the event that you do find someone who has like a large grade aortic plaque that's flapping in the wind or something like that, or some papillary fibroblastoma or something else that could account for this embolic stroke, I think that there is somewhat of a burden to do that before we implant this monitoring device. And so that's how I made that decision. There is not agreement across all the neurologists, and I have come across some that don't believe in that.
Okay. Well, again, thanks both of you for, I think it was really excellent.
The preceding program is copyrighted by Emory University.